What the meningioma is found typically surrounding the central nervous system. It is typically a benign tumor, but has a natural history where it can turn, unfortunately, malignant if untreated. From the radiosurgical point of view, we are mainly interested in the intracranial lesions, and they usually originate from the surrounding tissue of the brain, which is lining the cranial vault. These lesions are, even though benign, posing a risk because with growth, they inevitably will cause compression of the brain and neurological impairment. So the sooner they are treated, the better that is. There are multiple modalities, and the most minimal invasive would be stereotactic radiosurgery. Nevertheless, not all lesions are suitable for stereotactic radiosurgery because they might be placed too close to very eloquent parts of the brain which do not tolerate radiation treatment very well, for example, the optic nerves or the optic chiasm, and therefore a specialist opinion is definitely required to establish if that is suitable or not. Meningiomas, you can have genetic predispositions for multiple lesions. This can usually be genetically tested. It is often associated to neurofibromatosis type 2. Normally, this is a very rare presentation, often already presenting patients in childhood with multiple lesions throughout the CNS, not only meningiomas, but schwannomas as well. That is a very special indication if that happens, and it needs to have a special multidisciplinary input. Typically, meningiomas, sporadic meningiomas, so single lesions, are not genetically predisposed. In the presentation of meningiomas, sometimes this is only headache. Often they get identified even nowadays incidentally because patients go and have MRI scans of their brain for other reasons. And these lesions are identified in such circumstances. Interval imaging would be the modality of choice to see how this lesion is behaving and if treatment is required at all. The imaging technology has massively improved, and on MRI scans we see these lesions now when they're even very, very small and most likely not in any way symptomatic. On the other hand, patients might present with impairment of cranial nerves. That might be hearing loss, that might be tinnitus, this might be visual impairment, it might be swallowing problems. So there is a wide spectrum of presentations. Some patients present with seizures. So there is a very wide spectrum, and it is important that this is all evaluated in a specialist clinic and set up. It depends on the age of the patient. It depends on the location of the tumor and the growth pattern this tumor exhibits. So sometimes these lesions can be static for many, many years or even for decades and may not grow at all. So it is a very individually tailored need and treatment pathway which each patient requires depending on their very personal circumstance. Depends. It is either expectance, interval imaging on an annual, typically on an annual basis, because these tumors typically grow 1 to 3 millimeters per year and not more. When they grow, treatment itself consists of either surgical resection, that's the most invasive way forward, and sometimes, and in many circumstances, that might be the best way forward. On the other hand, if the lesion is suitable for stereotactic radiosurgery, and that is dependent on location, on surrounding tissues and size, i.e. volume, then this minimal invasive technology might be the most suitable way forward for a patient harboring a growing meningioma. For that, it is important that these patients are all evaluated in a multidisciplinary setting and to consider all these three options to tailor the treatment for each individual patient carefully.